Welcome to the KwaZulu-Natal Mental Health Advocacy Group's 6th Annual Mental Health Symposium. My name is Suvira Ramlall, a psychiatrist and academic working in the public sector in Durban, South Africa. And today I'm accompanied by my colleague Suntosh Pillay, who's a clinical psychologist who also works with me in the public sector psychiatry in Durban. We're also accompanied by Chantelle, who's a global mental health and youth advocate who works independently with different local and international organizations. It gives us great pleasure and a much needed mental health boost during this pandemic to be able to host this symposium despite the restrictions of lockdown. Now, every year, our advocacy group looks forward to our 2 flagship events, the symposium and our annual World Mental Health Day walk, when we can connect with our fellow mental health care activists and advocates on both an academic platform and then later in a fun-filled walk on the beautiful promenade of Durban's sunny beaches. However, this year COVID compliance necessitates this online platform for our symposium, and there will be multiple decentralized pockets of mindful mental health walking, which will take place on October 10th. In the true spirit of mental well-being, we remain grateful that the blessing in disguise of these lockdown measures was that we are able to still connect with you locally and with our international speakers on this online platform. The aims of our symposium are to unite all mental health stakeholders, clinicians, academics, mental health care practitioners, policymakers, educators, researchers, as well as those with lived experience on a common platform, and to facilitate information sharing that can translate into global mental health action within our family, social, academic, research, and workspaces. In short, making mental health everybody's business every day. This year's theme for our symposium is Surviving and Thriving, and it speaks to the various stages of the COVID-19 pandemic, its aftermath, and the implications policies and practices in the upcoming decade. The pandemic has posed a threat to mental well-being at many levels, isolating people from their usual support systems during a time of greater need and reducing access to both formal and informal salutary and therapeutic activities at a time of increased need. Having all the ingredients of a mental health disaster, it also affords us an invaluable learning opportunity to define a new vision for global community mental health. It is a privilege and honor this year to have an illustrious line of speakers who are champions on the global mental health platform. Professor Vikram Patel and Professor Miranda Wolpert. We bid you a very warm welcome and thank you for so graciously accepting our invitations despite your very busy schedules. We are grateful to you for sharing your vast experience and wisdom as global mental health experts with our local mental health community in Durban and South Africa. I now hand over to Suntosh, who will introduce you to our audience before we commence our panel discussion. Suntosh.
Thank you so much, Suvira. I think that was an absolutely apt welcome. And I think this is the closest to celebrities that I've ever had the honor of being on a panel with. And I think in the mental health profession, very few people kind of reach celebrity status the way Miranda and Vikram have. And certainly both of you are the 2 people who were first on our list of potential speakers that we wanted to invite into today's symposium. And it was absolutely mind-blowing that both of you, without hesitation, graciously accepted our invitation. It's sort of that list of people you'd love to have lunch with and pick their brain about topics that we're all jointly passionate about. And we have followed and admired your work from a distance based here in South Africa. And so we're familiar with the great stuff that you're doing. Your full bios and links to your more extensive CVs have been put onto the invitation that was sent out to anybody that's tuned into the symposium today. But certainly we want to do justice to the people that you are. And so I will be highlighting a few points from your bios so that the people who are watching today, just in case they've been living under a rock or in very hard lockdown, don't know who you are. So I'll start with you, Professor Miranda Wolpert, who also has the title of MBE, which I don't fully quite understand, but I do know it stands for Member of the British Empire. And maybe you can tell us a little bit later on about what that prestigious honor actually means. But Miranda, for I think just over a year now, has been heading up the mental health priority area at the Wellcome Trust. And this involves overseeing a ring-fenced fund of £200 million to develop a new generation of treatments and approaches to help young people with anxiety and depression. So it's certainly no easy feat, and I can't even picture how many zeros are in that vast amount, but it certainly sounds impressive. And obviously Miranda's overall vision and the vision of her work is a world where no one is held back by mental health problems. Miranda is also a professor of evidence-based research and practice at UCL, and she founded the Evidence-Based Practice Unit, which is dedicated to bridging research and practice in youth mental health. She also has extensive experience as a clinical psychologist for NHS England and in schools, and has experience working with young people. And this led her to co-founding the Child Outcomes Research Consortium, which is a learning collaboration focused on understanding the impact of mental health and well-being through collecting and using outcome evidence. And I'm really curious to pick your brains, Miranda, about how to measure outcomes in very kind of complex interventions. And in 2017, Miranda was awarded an MBE, which she'll tell us more about later on, for her services to children and young people in mental health. As a young clinical psychologist myself, I'm really eager to have this conversation with you, Miranda. And thank you for so graciously accepting our invitation to be part of this conversation today.
Thank you.
Vikram Patel is the Pershing Square Professor of Global Health. And Vikram, I hope you'll let us into what Pershing Square Professor actually means, because I'm not too sure. In the Blavatnik Institute's Department of Global Health and Social Medicine at Harvard Medical School. I think whenever I think of Harvard, I think of very important people, and this might be the first interview I've done with someone based at Harvard. So he is an adjunct professor and joint director of the Center for Chronic Conditions and Injuries at the Public Health Foundation of India, honorary professor at the London School of Hygiene and Tropical Medicine, where he co-founded the Center for Global Health in 2008, and is co-founder of Sangat, which is an Indian non-governmental organization which won the MacArthur Foundation's International Prize for Creative and Effective Institutions in 2008. And he's also a World Health Organization public health champion for the incredible work he's done in mental health. Vikram has also had the illustrious honor of being on Time Magazine's 100 Most Influential Persons of the Year list in 2015. And we had a little joke about this yesterday, Vikram, that apparently Kim Kardashian was on the same list. And I think both of you are incredibly influential, but in very different spaces. And Vikram's also affiliated to the Wellcome Trust as a Principal Research Fellow, and also a professor in the Department of Global Health and Population at Harvard T.H. Chan School of Public Health. I'm going to stop there because I know I can't do justice to Vikram or Miranda's full bios and CVs. But for everybody who's watching this panel today, I think I just want to give you a sense that it's a great company that we're in. And these are people who we can learn so much from, not only in their clinical, but also in their research work, but also in terms of being incredible role models for all of us who are working so hard to make mental health matter in the world. And having introduced the two of you, I would like to just perhaps pose the opening question and allow our conversation to flow from there. And I think perhaps the best way to start is to look at the current context that we're in, which is the COVID-19 pandemic. And I think without a doubt, this is an unprecedented time in human history and certainly in our lifetimes. And although the world has gone through different pandemics in different eras, I think for most of us in our living memory, this is the first time the world has been under siege in the way it has by a single virus. And without a doubt, there's this parallel mental health pandemic that's been following the COVID-19 pandemic. And I was quite interested to hear your thoughts on how global mental health specifically has been affected by the COVID-19 pandemic. And Miranda, perhaps we can start with you, and Vikram, feel free to chip in.
Thank you. Thank you very much for that wonderful introduction. I've put in the chat, and if it's missing, I'll put it in again, a link to a position paper that the Wellcome Trust have just published about mental health in the light of COVID, where we're trying to learn from people's experience globally as to what it might mean. I think our position, and I'll be very interested to hear if this chimes with Vikram, is that the COVID pandemic has highlighted an existing major problem in mental health. It hasn't created it, and that our solutions have to be creative and thoughtful. And in a way, in our position paper, we're suggesting three things in particular: that anything we do in global mental health must involve lived experience at its heart, and must take the views and perspectives of people who actually experience mental health problems as our starting point. The second thing is that we need to look at local innovation and not assume there's one size fits all, that we need to understand what will work in different cultural contexts. And the third is that we need to think bigger than healthcare, that mental health is bigger than health. So thinking about economic interventions as much as healthcare interventions, about social interventions may be really important. And I guess one of the frames we took when we were doing that work and thinking about COVID and mental health was thinking both about what we could learn from this pandemic as well as what the sort of negative impacts of it had been. And one of the things that emerged is an opportunity for people to think differently about the new world we're all going into. And so I just want to circle back a bit to your question about the MBE, because in a way it sort of links. So the MBE is member of the British Empire, and it's an award that you're given by the royal family in the UK as a sort of marker of public service or doing something good for the community. But I and other people have been started a campaign to say, can we change the name? Can we decolonialize that name? Because empire is not necessarily how we want to be associated. So there's a movement to change it to be member of British excellence. That's the idea. And I think that links with the wider issues. Does COVID give us an opportunity to rethink how we think about structural racism and inequalities, and what do those mean, and how have they affected not just how we respond to COVID, but also how we respond to global mental health? So at that point, I will leave Vikram, who I know has much to say on these issues.
Well, thank you, Miranda. Thank you. I completely agree, of course, with all the three broad principles that you mentioned. But maybe I'll just pivot back to your broader question, Suntosh, about what is my take on the impact of COVID-19 on global mental health? And I would say the most important take is that I've never, ever seen a better opportunity to actually put mental health on the agenda. I have never seen a time, at least in the last 6 or 7 months living in India, where I've been locked down, where mental health has been so prominently in national and local conversations, that there has been such a massive interest in mental health. If I had to look at all the health conversations after COVID-19 itself, and the specific health risks associated with the disease, the next most important conversation is about the mental health consequences. So I think, first of all, in terms of opening up conversations at a public level, I have never seen anything like this in the last 25 years that I've been working in this sector. So it's an incredible opportunity. The other interesting thing is that the conversations are actually quite broad. They don't follow, I think, the old narrative that was very restrictive, a very narrow biomedical framing of mental health in the form of othering or binaries of disorders, drugs, and doctors and diagnoses, but a much broader conversation that embraces the plurality of experiences of mental health distress, the need not to pathologize all of these reactions to the incredible uncertainties that populations around the world are facing, but instead to embrace this as a part of the normative human reaction to very unnatural stressors, and to be able to understand that in that broader context, but also to recognize that a lot of these individuals, many people do need interventions. And by interventions, again, I totally agree with Miranda, the conversations go way beyond the narrow biomedical interventions. They include, for example, giving more accommodation to young mothers who are working from home and also have kids because the schools have locked down. The fascinating conversation that recognize issues like gender inequity, structural problems like inequality, and the particular needs of rural populations, etc. So I think this is very welcome, and it's a real historic opportunity in my mind to really get those changes, the radical changes that we have all been calling for a decade or so, to realize some of the incredible science that global mental health has produced and put it into practice.
It's wonderful that mental health has been, received so much of media attention. But my question is, how do we utilize this, the momentum, and how to advance the interests and needs of mental health globally? And more importantly for me, how do we sustain the momentum that we have gained thus far beyond the pandemic? Because, many people during the pandemic, they reach out for services, there's lots of interest, but you find that once the crisis is over, people just go back to, business as usual. Any thoughts on that?
I'll let Vikram start and I'll come in.
So, this year's World Mental Health Day theme is invest in mental health. And I think obviously this is something we can all agree with. I think you're absolutely right, Suvira, to say that this is a moment and the moment will pass. And so it is actually an incredibly important and urgent opportunity for the entire global mental health community to speak with one voice. That is not to crush different points of view, but instead to find the common areas of agreement and ensure that we speak loudly and unitedly around some common themes. And I think the themes that Miranda spoke about, I think, are really wonderful examples of those. I can't find any reason why we would find any disagreement around those themes. I think we need to do that. We need to use October 10th as a unique opportunity to shout out loud so that everyone hears us. And I would also want to say is that we have to be very clear that the increased investment that we are calling for is put to the best science. I think it's extremely important that we don't say it's more money for the same old business as usual, but instead it's more money to actually reframe conversations around mental health and mental health care in the way that we all recognize is what science shows us is the direction to take.
Completely agree. And I think that it's a moment to enlarge the concept of who needs to invest in mental health. So yes, we need government investment, but we need civil society investment. This is a moment when workplaces have understood that mental health is core to the people they are employing, when schools and universities have understood that mental health is a major issue for them and a major challenge they need to address. And all those aspects of civil society, including individual philanthropy giving, need to be harnessed into the mental health community. Compared to other conditions, we do not have a tradition of people even understand that you need to invest not just in mental health services, but in mental health science. If, as Vikram said, we are going to find better solutions and new solutions, building on what we already know and making it more effective, then we need to invest in the science, and that needs to come from a wide range of investors. And making clear arguments about the impact of that, both economically and socially, is going to be something the mental health community needs to really be clear about.
Miranda, can I just pick up on the point that you made? Because I understand that you're in your role at the Wellcome Trust for probably just over a year now. And I mean, when I think of the Wellcome Trust, I just think of this organization with a ton of money that's going to fund innovation in mental health around the world. And I was quite curious to know how the funding landscape is changing and might change as a result of COVID-19 and the implications that has on mental health. And are there any kind of things that you've picked up in terms of trends, and perhaps any pointers that you have for people who might be thinking of applying to the Wellcome Trust?
So I think we're about to be involved. We commissioned a report with the International Alliance of Mental Health Research Funders, which I think is due out very shortly, which is a review of the funding landscape. And you know that the MQ charity did a funding review in the UK, and then there's been a review internationally. I think, like others have said, this is a moment of opportunity, but we also have to be realistic. The funding in mental health has been dire, absolutely dire. And that there is a real danger. My biggest fear is that everyone will talk mental health and no one will put their hands in their pockets. And my biggest fear is with COVID, that will make it even worse, because we are going to hit economic crisis. There is going to be many, many demands on funding. And so that even at the same time as everyone's talking more about mental health, we may actually see a reduction in funding. I'm not wishing that, but I am concerned about that. So I think we need to be realistic that that is the context. Those funding landscape reviews that I've seen so far show very little change over the last 5 years, despite the fact that there's been massive more talk. So I think we've got to, I don't think we should underestimate the scale of the challenge. On a more positive note, I think people are poised. There are high net worth individuals and communities and organizations and workplaces and others that I think could be brought in if we can get a coherent message and a coherent community going. We at Wellcome are working as part of a big initiative called the Healthy Brains Global Initiative, which is trying to galvanize a global fund that will bring new finances into mental health science. Within Wellcome, we have 200 million, as you say, ring-fenced for the next 5 years. And that's just part of our portfolio. We also do other research funding in mental health alongside that. And mental health is due to become a bigger part of Wellcome's portfolio rather than a smaller part. And there should be more information about that coming out shortly, which is very exciting. I think that in terms of people applying to Wellcome at the moment, look at our strategy. It's all online. We've had several commissions and there'll be some more commissions coming out next year. Anything that links to our strategy, we're really interested to hear from people around. Our focus currently is very much focused on youth and anxiety and depression, but we also have a stream looking at innovation in psychosis and then more discovery-based science if people are interested in the more basic science initiatives. And we are a global funder. We are interested, and we're particularly interested in capacity building in low and middle income countries and working more globally. So we're really interested to hear from people about any ideas they have about that.
Chantelle, can I bring you into the conversation at this point? I mean, being our globe-trotting youth ambassador, I'm sure you have some interesting thoughts about what Miranda and Vikram has said.
Absolutely, thank you. I think, I have been working with the Wellcome Trust for the last couple of months, and it's been such an amazing space to be able to consult in a way that's actually quite refreshing. Just working with Kate and being able to explore different concepts and ideas in quite an organic way. And I really appreciated that space that we can, collect all of these thoughts and ideas in that space and in that way. So I have been specifically very excited about the way that youth mental health has been driving and involving young people, involving people with lived experience. I think there's been a massive drive to be able to include people, very diverse people in different conversations. And I think that's something that certainly has to remain on the agenda and needs to be pushed forward. But I think, Vikram, I absolutely agree with you when you say like investing in base science and investing money into science. Specifically, Miranda, you also mentioned that. I think what I am sometimes struggling with, and I think the ideas that I struggle with, is the fact that we are trying to get governments to invest in something, and then we have external donors and funders investing into something different. And perhaps like understanding how do you align that, and also because there are challenges with the way that funding's been done on a government level, internally in different countries. So perhaps maybe you can give me your thoughts on how do we actually then, what are some of the ways that we can actually align those so that they actually do work together and in sequence and in unison with each other so that everyone benefits from it.
So let me have a go first. You know, this is a very big challenge. First of all, I want to acknowledge what Miranda said. I do think that this is a moment. I had stressed that earlier, and the moment is going to pass. And it's already passing in some ways in many countries as the pandemic, the acute phase has sort of begun to move on, and you can already see that the attentions are focused on you know, almost all the money of many of these major funders is entirely on things like diagnostics for COVID and vaccines and so on. And when the vaccine is going to come, it's going to gobble up, you know, a huge amount of the, you know, there's no new money. That is the irony here, you know, because actually there's less money because everyone's economies have come down, and a lot of aid is actually a proportion of the economy. It's a proportion of your GDP. And so if your GDP collapses, well, reduces, well, your amount of aid is going to reduce. And so the pie is shrinking, and there is a whole slice of that pie that never existed 8 months ago, which is COVID. And that has suddenly gobbled up a huge amount of that pie. And so we shouldn't fool ourselves for a moment, as Miranda rightly points out, that, you know, simply because there's a huge amount of media interest and all great leaders are talking about mental health, that's actually going to translate into any pennies. And I think that's really what we have to be very mindful of. Now, the question you're asking as well is about fragmentation, Chantelle. That's how I see it. The fragmentation at the level of government and also at the donor level around issues of mental health. If it is the case, for example, as we all believe that mental health interventions have to go beyond the biomedical, well, that clearly means that we have to go beyond the health sector. And unfortunately, the moment the word health comes in, or illness or health problem is dealt with, all the other ministries will say, well, that's not our problem. That's the Ministry of Health. And the Ministry of Health will say, well, our sole focus is diagnosing people and giving them a medicine, because that is really what mental health care looks like for the vast majority of ministries around the world today. You know, there are very few countries that have been able to embrace a plural understanding of mental health within the domain of health in the way that we all believe should be done. So this is a very big challenge. You know, for example, let me give you one very important example, and then I'll hand over to Miranda. A very important concern in global mental health is to do with the issues around coercion and the issues to do with inclusion of people with serious mental illness into communities. Now, a lot of that has to do with issues like housing. You know, a key element of that is good quality supported housing. Well, no Ministry of Health I know anywhere in the developing world sees housing as part of its mandate. So you can begin to see how a very important part of the interventions we need to support people with serious mental illness actually fall outside the health sector totally. And who's going to pick that up? It has to be the Ministry of Housing, but the Ministry of Housing probably doesn't see the needs of serious mental illness as being germane to its broader agenda. So how do you have intersectoral working? I've thought a lot about this, and one possible way of dealing with mental health, because it is so fundamentally intersectoral, is to do what many countries do with HIV/AIDS, is to actually create, and India did this, so I can speak in the, you know, with India in mind. You create a separate intersectoral kind of mission in the government, which is typically led, in India's case, by the Prime Minister. So it's something that is given really high-level importance by someone who is above the ministerial sectors. And it's got a clear mandate of representation of several ministries or departments that have a stake in mental health, a role in mental health. And they use resources across the ministries to coordinate investments in mental health so that no one falls between the stools. Ironically, I think there is a lot of money in all of these different sectors, but they're not being harnessed in a convergent way around issues to do with mental health. Miranda.
I think that's a really interesting idea, and I think that makes a lot of sense. I think there are also opportunities for partnerships between governments and other bodies, whether it's workplaces or other, where there could be matched initiatives. You know, if you think about the commercial sector as someone that's very interested in mental health, there could be some really interesting partnerships that I think need to be brokered in a thoughtful way. I think recognizing the shrinking pie, and that COVID's got a bigger slice of it, and that mental health has had almost no slice of it, to try to carve out a slice, where's it going to come from, means having arguments about how it helps other broader agenda. So I think being very clear of thinking about the impacts beyond health and beyond the individual is something that needs to be really thought about carefully.
In terms of how much people take mental health for granted, you know, in their day-to-day lives, and obviously with the demands made by lockdown and the nature of the pandemic, it really threw into sharp focus the importance of people investing in their mental health on a regular basis and developing resilience. So I like the idea of, my approach should be, the approach should be a top-down, bottom-up approach. So we can wait for government to kind of see the light, but we can't rely on that, because I'm not totally optimistic that that would necessarily happen due to the challenges as Vikram has highlighted. But what can communities do, to kind of a bottom-up approach? How can they empower themselves? How can they mobilize resources and perhaps advocate for better mental health support? And I'd like the emphasis to be on mental health support in general, rather than mental illness treatment. Because I think that's something within the capability of all societies to invest in their mental well-being.
So one of the things I posted in the chat was this work we commissioned. We commissioned 2 cultural pieces. One was called COVID Living and one was called Collective Resilience, and both of them are on our website now. And they were attempts to try and source what communities were doing during time of COVID to support each other's mental health. And one of the things that really struck us, they're not research pieces, they're cultural engagements, was around how many diverse ways different communities have come together to support each other, whether it's from mutual aid to volunteering to digital initiatives, how quickly some of the things that have been real challenges for mental health support move to digital work. And we need to make sure we don't row back from those things and really learn from them. It isn't that they can replace everything else, that we still need all sorts of other sorts of contacts, but there is an opportunity to really learn from those initiatives. And also, exactly as Vikram's saying, recognize that these are all part of a family of interventions for mental health, ranging from how a community supports itself to how people go gardening and what they do to support their well-being and how they engage with nature, right through to whether they choose to take some medication at some times for some particularly acute difficulties. And in a way, starting to conceptualize it in those terms and think about whether you're prescribing gardening versus whether you're prescribing medication as part of a panoply of sort of active ingredients for what will really make a difference to people's mental health.
Yeah, I completely agree with Miranda. But one thing, Suvira, I do think that you need both actions, top down as well as bottom up. I completely agree with you. But I think we should be very clear that bottom up actions that go beyond mental health promotion will require very strong support from the top. Volunteerism is something we should all celebrate and actually encourage. I think it's a very powerful way, not only to help one another, but also to help yourself. I think we all know that compassion and caring is a very powerful tool to promote your own mental health. But equally, I think it's also very important not to sort of give that sense that actually communities have all the resilience in them, and all we need to do is to figure out how they can manage mental health problems on their own. I think you and I know very well that we need both to happen in concert. And we need very strong support from the state. So for example, a lot of our work in India and now in the US is to get community health workers involved with mental health care. And I have to say, and a lot of that work is actually building community resilience, for example, in groups, self-help groups and so on. But none of it can actually be really, really practically scaled up without very significant commitment, both in terms of policy as well as financing by the state.
I think that's right. I'm glad we could find a small moment of contention, which is always more fun in a debate. So I agree with you that we need both. I think where we may slightly have shades of difference is how far it needs to be healthcare professionals involved in that, and how far it's other actors that may be involved. So I'm not completely convinced, and I just don't think we know the evidence yet. So you may well be right. I just don't think we've looked at it scientifically. If we got a really good housing structure, if we got a really good income equality structure, would that address some of the issues that we're now having to pick up afterwards with healthcare type interventions? And I don't think we know, and I don't think it's an easy, just sort this and everything will be okay. But I think getting the balance right between those things is still, the jury is still out. And I think there's a danger of assuming, because we've focused on healthcare, that those are going to be the people that teach the communities. And there may be things from the communities to teach healthcare. So I think it's just trying to get that balance. We may just be disagreeing at the moment about where we would place our bets and where the balance would lie.
The actions that communities take to address structural factors is a good in itself, Miranda, for me. I wouldn't promote that because it helps mental health. If communities take actions in order, for example, to reduce inequality, violence, take care of people who are actually hungry and homeless. To me, this is an end in and of itself, regardless of whether or not it improves anyone's mental health. And I would see those as being complements, essential actually. What is missing actually often in many communities is an acknowledgement of the mental health sort of dimensions of this kind of work, which also therefore then gradually sort of, I think in a seamless way, crosses over into also supporting people who are already in distress. So I think we're not disagreeing at all. I think I see this very much as part of a continuum of community actions that addresses social determinants, and then moves gradually to people who are facing a higher level of risk, and ultimately to people who in fact are already developing distress signals that require help. So yeah.
So I just want to ask, we've ushered in the new decade in quite a dramatic way, and I think there's lots of opportunities for us to kind of build on the momentum that mental health has gained. What would you like to see the mental health platform looking like globally in 2030? And what could be the first steps that we need to start taking now to be able to realize that?
Wow. Okay. Well, I'm leading a 10-year program, so I have all my objectives around 2030. So I can tell you exactly what we're trying to do at Welcome. So at Welcome, we're trying to build a mental health science community that is more inclusive and more diverse than it is currently, where people would introduce themselves as I am a mental health scientist, not I am a neuroscientist or a psychologist or a psychiatrist. So that's one thing. And that mental health science community has common metrics, that it has a clear way of measuring things that is the same, or at least some elements are enough the same, that it has a greater understanding of what helps whom and where, using a common language, and the language we're hoping will be used by 2030 is that of active ingredients. So what are the core things that make a difference, separate from traditional models of my intervention X versus your intervention Y, but more about what are the core ingredients that we can all agree whichever unique intervention we're doing. And that out of that, we have more effective ways of helping that may range from things that communities do to things that healthcare people do, but that will actually lead to fewer people being held back with mental health problems in the world. And that there'll be more funding as well. That's the other.
So I agree with that. I mean, I just wanted to add, there is a wonderful World Health Organization mental health action plan that actually may even coincide with your timeline of 2030. And it's worth looking at. I think it was put together with a lot of thought, and it has these 4 vertical kind of broad goals, and I think they coincide, almost completely with what Miranda has said. But also importantly, they were signed off by every country in the world. And so, it's a kind of a document that has official status as a plan that every country in the world has embraced and signed off. It is also accompanied by a number of different metrics that can be used. And so one of the things I'm hoping that at every country level, people like yourselves actually, are really organizing and mobilizing yourselves to hold your country accountable. I think what's really missing isn't just money. I mean, we can spend all the money, but also an accountability mechanism to see what the impact of that money is. Is the money being well spent? Is it having the desired results? And for those of you who are interested to actually look at what kind of outcomes have countries agreed to, and it's not making them up just because I think it's important, but what have actually countries and ministers agreed to, just have a look at the mental health action plan. It spells it out. And I think those would be an initial batch of indicators that local community groups, civil society organizations, groups of people of the lived experience can actually play a profoundly important role in holding countries accountable for what they've signed up to.
That's wonderful to hear. And I think with Miranda and her vision for the next 10 years and Vikram, with your influence on a global platform, I'm just thinking that the 90s was declared the decade of the brain. And maybe we could declare the next decade, the decade for mental health. And that would really be a coup for us if we can really advance all of these ideas that we've been discussing and really make a mark in terms of mental health. Back to you, Suntosh. I think we're running out of time, so perhaps some concluding comments or questions.
Sure. I want to just bring Chantelle back into the conversation. But before I do that, I just have a follow-up question, which is related to the remarks that Miranda and Vikram made early on. And I mean, this is, I suppose, a question that's personal to me, but I'm sure people who are watching this will be interested in, which is, what advice would you give to young people like myself who are emerging scholars in community mental health and perhaps even global mental health, especially those who are situated in the global south? Where should we direct our skills, our energy, and our resources for the next decade? And if we had to have this conversation, like Suvira said, in 2030, and what are the kinds of hopes and dreams that you have for a kind of younger generation and younger cohort of mental health practitioners and researchers?
I can start, and then Vikram can join. It's not by chance that Wellcome have chosen to focus on mental health in youth as a starting point, and it links with a wider agenda around trying to change science and trying to increase the voice of young researchers and early career researchers, and also trying to redress the balance between the global north and the global south. So I think in all those ways, the ambitions are there. I think we need to be realistic. There's a way to go, and the world is still controlled by older people from some continents and not from others. So I think my hope would be from 2030 that in a way the power is passed, and we've created structures that allow greater power and voice for younger people earlier. And we really are looking for ideas around how best to manage that. So for example, on the position paper that we've just published on how we want to embed those 3 principles with the World Health Organization and UNICEF and the World Economic Forum, we've agreed that we'll have a group of young people who will hold us to account, who will meet with us and review how we're doing. In terms of thinking about where we're committing our funding and our research funding, we are committed to try and prioritize early career researchers and those from the global south, but that needs to be balanced with trying to get the best research in place. So we're trying to work out, how do we create a mental health science community that respects knowledge and age and experience, but also brings on new ideas and can pass on the banner to a new generation. So very much open to ideas and thoughts on that.
Well, I mean, I think that just being committed to mental health in the way that we've discussed earlier, beyond a narrow biomedical focus. Examples of those we've already discussed, but one of them, for example, could be the integration of psychological and social and structural interventions into a kind of a composite. I don't believe these are all separate. I think they're all part of a continuum. And to be able to embrace these diverse ways of thinking about mental health would be the most exciting way forward for any younger person who's entering into the sector. And I think also inspiring, because what it also does is it removes the hierarchies. And I think that's one thing that I believe that in our sector has been a particularly problematic and troubling barrier, is the hierarchical nature of the professions. I think you know what I'm referring to. And then also between the professions and the rest. And these very, very robust hierarchies are unhelpful. They also suggest kind of a level of importance that is given to certain kinds of knowledge, expertise, and interventions. And I think we really do need to challenge that. And the science shows that, in fact, that is not that doesn't actually bear out in the real world.
That's really helpful. And just to share one other thought, that just on a very practical note to answer your question, Suntosh, I would really encourage young people to team up with other people who are also mental health scientists, but from a different perspective. So a technologist or a data analyst or an anthropologist or an economist. I think there are opportunities here for a new sort of mental health science that the traditional models really struggle to accommodate, which the new generation can really find to form relationships that are more creative and more lateral. And I think that your generation can really help build that and help take that forward.
Thanks, Miranda. Thanks, Vikram. I think that kind of interdisciplinary nature of kind of mental health science is so important, and probably links back to what you spoke about very early on around decolonizing mental health and moving it away from this kind of narrow silo that is the exclusive domain of psychology and psychiatry in most instances. Chantelle, I'm going to kind of give you the opportunity to ask, I suppose, what might be the last question, and then I'll do a little bit of a wrap up after that, and then I'll hand back to you to do a thank you.
Perfect. I wanted to add to that because, yeah, thank you, Vikram, because I think the idea of having people with more experience and having access to people with more experience as a young person. I'm very soon not a young person anymore, so I'm trying to be as young as I possibly can for as long as I possibly can. But I think that accessibility really does create a sense of validity for young people, and also, being able to learn and being able to, I feel like young people are very eager to learn. So it's not that they don't want to learn, I think they just want to learn from the right people. So having access to people like you is very, it's great, and it also really helps the narrative. I think I wanted to ask the final question, and it is really nothing too heavy, but I wanted to, this year's mental health, there is a campaign, Move for Mental Health, and we will be hosting a mental health walk, and it's our 5th walk in Durban as well, and we've been gaining quite a lot of movement and momentum with our walks in the past years. And we wanted to find out, what I wanted to know is, what do you do for your own mental health? Because often I know very well how this goes. You, especially when we are in COVID and we sit in our room and we're behind our computers all day. And Vikram, I know you have at least 15 webinars just this month. I've seen your face everywhere. So I just want to know, what do you guys do practically for your own mental health? And be honest.
All right, let me go first. So I do a lot of things. First of all, I'm very, very aware of my mental health. As I assume everyone should be all the time. So I have a number of very simple things I do, nothing that can't be done by anyone else. I always wake up at a very particular time, no matter what time I go to bed. I always have several breaks in the day to read. By read, I don't mean work, to stay away from the computer. Until the swimming pools closed down, that was my exercise. I used to swim every single day, and I've done that for 30 years. That's been my most important narcotic. And most importantly, I have had an incredible opportunity to reframe my life by spending 6 months with my son, who I haven't been living with for 5 years because he was in university. And so it's been a miraculous, unexpected gift in that sense. I can see the positive. And I'm constantly seeing the positive of how the pandemic and the lockdown has allowed me to reconnect with him, with my little dog, for me to reconnect with my village, the people who live in that village, who again for 5 years I had really lost connection with. So this is something that I have, and most importantly, it's a structure, a very clear structure to my day. Because remember, I'm locked down in India, and my work begins in Boston, usually at about 3 o'clock in the afternoon, India time. So I actually work till late in the evening. So there's a need to have that structure, and that's been very, very helpful for me. Miranda.
Gosh, yours sounds much more sorted than mine. I'm trying to think, mine's a bit more random. So I'm standing as I talk to you on a walking machine that I can sometimes walk in while I'm on meetings, and I find that very helpful, but I have to turn the camera off to do that. Otherwise my bobbing head is a bit irritating for the people I'm speaking to. I also like swimming. I also find that a big release. Going for walks. I think the things that have helped me, and just to be really honest, Chantelle, I probably watch more TV during lockdown than I normally do, and I found that very relaxing. I've discovered some box sets that I would never have discovered. I've discovered having lunch with my husband, who's also at home, is actually quite enjoyable. And we go for walks in the park, which is always very enjoyable. And I suppose focusing on the small things, like just seeing nature change and just sort of enjoying sunny days and not sunny days. But I think what I have experienced, and I know others have, is that it has been a bit of a roller, there have been days that feel better than other days. It hasn't all been joyous or all terrible, but it has been, I think we've all been more aware of our emotions going up and down during this period than perhaps would normally be the case. And sometimes that involves chocolate.
That's fantastic. Now, I have certainly seen some of your Twitter updates, and it seems like you are really downplaying your swimming skills, because the amount of times I've seen you swim lakes, it's extraordinary. I live right next to the ocean and I can't swim like that. So kudos to you.
So I would just want to add to the chocolate remark, Miranda, I have discovered that I adore gelato. And in the last 6 months, I have been eating gelato like I've never eaten gelato for the previous 50 years of my life. So, obviously there must be some common angle there.
There is.
That's fantastic. Thank you, guys. That's really helpful. Thank you.
Chantelle, I think we've only got about 3 minutes left, and I want to just respect the time that Vikram and Miranda have given us, and not go over the allotted schedule. So I'm going to kind of just hand back to you, just to thank Vikram and Miranda for their time. I've got 100 more questions. So if I ask another question, it's going to be going down a rabbit hole. And hopefully our paths can actually cross in real time, in person, probably not this year, but hopefully in the near future. And I mean, that'll be kind of my wish for the next year, at least, that somehow, somewhere, we get to actually sit down and share a meal and take this conversation to the next level. It's been completely enlightening and interesting to me. I can't believe almost an hour has gone, but we've got about 2 minutes left. Chantelle, I'm going to hand over to you to do a little thank you, and then we'll just wrap up this conversation.
Thank you. Again, I just wanted to say thank you to Suvira and to Suntosh again. It is really incredible working with both of them. And I am sure if you both meet with them in person, you would also adore them as much as I do. But again, thank you, Vikram. Thank you, Miranda. It is always a joy to be in your conversation, and always enlightening and inspiring. And I'm looking forward to having more of those in the near future. And yeah, thank you for joining us, and thank you for joining our humble Durban Symposium that is now going global. So thank you for being with us. I wanted to ask one last favor. If you can smile, because that's good for your mental health. And secondly, while you smile, I'm going to take a screenshot, because that's going to go into our newsletter and possibly onto social media. So Vikram, I know you're not on social media. I won't tag you, but you'll be there, just so you know. Okay.
Thank you.
So 1, 2, okay, wait. I think, okay, 1, 2, 3. Perfect. That was so nice. Look at you. Thank you very much, everyone, and have a beautiful day. It was so nice to see you. Good afternoon, or good morning, or good evening, wherever you are. Thank you for joining in our 6th annual Durban Symposium. This specific conversation is going to enlighten you, it is going to invigorate you, and I'm really excited to be part of this. I wanted to introduce you to our moderator today, first of all. She has got quite a bio, and it is super impressive. So I'll read it out to you, and for you to get to know her a little bit more, and then I will start, or I will introduce the speakers to you. So Lorato Modongo is a social psychologist and currently a program manager for the Breaking Down Borders Africa, a youth platform that creates networking, collaborations, and partnerships between African youth movements across socio-economic and political spaces. She previously lectured research methodology at the Public Health at the Institute of Development Management in Botswana, and worked for the United Nations Populations Fund in Botswana in the gender unit. Lorato's primary areas of interest include knowledge creation on social psychology, gender-based violence, and African intersectional feminist thought. She is a psychology graduate from Stellenbosch University and University of Botswana. She completed an advanced course in civil society law with the University of Pretoria Center for Human Rights. Lorato is a 2014 Mandela Rhodes Scholar, a 2015 Mandela Washington Fellow under Civic Leadership, and a 2013 Women Deliver Fellow. She volunteers on a number of civil society, locally and internationally, and occasionally contribute to publications, including Mail and Guardian Thought Leader. So, thank you for joining us, Lorato, and thank you for steering this conversation. I'm really excited for you to be part of this. So, secondly, I wanted to introduce to you our amazing speakers, and both of them sent us their bios, which I think is terribly underrated. And I certainly think that, Lorato, you need to maybe advise them on how they should improve on their bios. So I will read you, I'll first read you Wenzile Madonsela's bio. Madonsela is a social entrepreneur, mental health activist, and a democracy defender. She is passionately dedicated to closing the gaps that social injustice creates in South Africa and globally. She dynamically advocates for and is involved in sustainable programs that are geared towards empowering people, specifically through enterprise development and mental wellness advocacy. Now, I've known Wenzile for a little while, and I can tell you that that bio doesn't do her justice. She has done an amazing array of activist work that has made some real changes in this country. And I can certainly say that her work extends far beyond those few lines that she has sent over to us. But we're very, very grateful to have you, Wenzile, and really happy for you to join the conversation. Grace. Grace, I am incredibly happy for you to join all the way from Rwanda. And Grace is a lived experience mental health and NCDs advocate living in Kigali, Rwanda. She works as an advisor for the Wellcome Trust Mental Health Priority Area and is a commissioner on the Lancet Commission on Gender-Based Violence and Maltreatment. She's also a young leader for the Lancet Commission for Global Mental Health and Sustainable Development. Grace is passionate about meaningful youth involvement, particularly for under-resourced and underrepresented and least heard populations in the world. And again, that bio certainly also does not do justice to all of the amazing work that Grace has done over the years, and also gives so much to her community and to different communities. There's not enough words to explain how much she actually does and give every day. So with that, I want to hand over to Lorato, and I would like to say thank you for joining us, and we will proceed.
A very good afternoon to you, Wenzile and Grace. Again, I'm very happy to be moderating this conversation with you. I was reading your bios, your profile, and I'm just amazed by the work, the incredible and necessary work that you do in the continent and in your respective countries regarding mental health advocacy. So how are you doing, Wenzile?
I'm doing well. I'm doing well. I love your lips. They're red. They don't lie. I'm happy to be amongst a group of dynamic and just incredible women and ready to steer this conversation in a way that has meaning and impact. And it's nice to connect from around all over the continent, just coming together under one banner. So
Thank you and welcome. And you know what they say, when in doubt, wear red lipstick. Has some superpower.
can feel it.
Hello, Grace. Good afternoon to you in Kigali.
Hi, it's a bit windy here today, but I too am very excited to be here. In fact, this might be the most excited I've been to do this ever, because it's just us African women, you know?
Yeah.
Yeah.
Keep it real.
Yeah. Yeah.
Yeah.
Okay. So welcome as well, Grace. So our conversation is just going to be, you know, a conversation, as we said, just, you know, try to talk and co-create knowledge and share perspectives around mental health advocacy and what we envision for the next decade. So I'm going to start with you, Wenzile, you know, looking or drawing from your own lived experiences, right? How have they shaped or rather like impacted your own desire and work in the mental health advocacy space?
I read that question and it took me aback, because I realized that everything that we advocate for and work towards as mental health advocates is a human experience. It's such a real, intimate, vulnerable human experience, you know, that incorporates many things. And one of the things as a mental health advocate that I've found is that once you understand yourself and create enough bravery or courage in your heart, it becomes a rippling effect. So as soon as you keep quiet and start speaking your truth, the ripples stop rippling, the waves stop crashing. But for as long as you as a person are speaking your truth, speaking your power, whatever it is, the thing is with the lived experience, it's a genuine thing. It doesn't have to have too many elements. It doesn't require PhDs. It doesn't require ratification from anybody. It is you and how you have identified with this real human experience and lived journey. So in that sense, it's shaped advocacy to me in a way that every single person, I see them with a new lens, because I understand that they're looking at life through their own lens, and I can't come prescriptive. It's as if an optometrist, going to an optometrist and you go and see them and then they give you glasses that they take the measurements and the prescription of someone else and put it on you and say that these are glasses and expect you to see. No, every time it's a fresh experience. It's new elements that play a role. So I've been challenged in that to not let my own lived experience as well to use that lens to look at someone else's journey. Everything is new. It's a fresh perspective. It's a new perspective. There are foundations in which we look at mental health through, which are the basic foundations. But ultimately, for me, it's been an incredible journey of intimacy with oneself and allowing that intimacy to find a place in society, to find a voice in society without feeling naked or without feeling that will be misused by society, and still feeling protected, because as I said before, it's quite a vulnerable experience in that sense.
Thank you so much, Wenzile. I really love how you brought in the aspect that the advocacy is also laced with a lot of intimacy and vulnerability, particularly in a world that sees advocacy as a one-size-fits-all, you know, and that is why sometimes in different contexts, different cultures, you find that one advocacy tool doesn't necessarily work in another culture. But I really love the intimacy and the vulnerability that you bring in, that allows you perspective to see everybody else as a new person on their own. So I'm just going to extend this question to you as well, Grace. Looking back and drawing from your own lived experiences, how have they shaped your advocacy in the mental health space?
Thank you. I really loved Wenzile. Can you hear me?
Okay.
Yeah.
Yes,
Thank
I can
you.
hear you.
Thank you. I really loved Wenzile's answer about intimacy and closeness, because that's not something you think about when you're going through a situation of any situation, actually. So for me, my journey with mental health started really young, like maybe even like a year old, because my parents were actually, even before I was born, because, you know, Rwanda and Burundi have been were in conflict in the 90s, and that's where I'm from. And my mom escaped during the genocide against the Tutsi. And so she definitely transferred something. I'm just saying. But growing up, I felt very, very isolated, very, very alone, because I grew up as a refugee with my parents in Uganda, and no one there could understand my experience because they had not had the same growing up. I remember feeling, you know, scared. I remember feeling things that I didn't really describe or put a name to, but that made me different from other people, and I hated it. I resented it. I just wanted to be normal, but I'd get anxiety, I'd cry, I'd get panic attacks. And so this went on until, at least, sadly actually, until 2018, when I was asked to join the Lancet Commission as a youth leader. And I met other young leaders, and I heard the term lived experience for the first time. And I think it made me feel very empowered. It made me feel things that I'd never felt before, because, you know, when you spent most of your lifetime experiencing mental challenges, you feel unable to control aspects of yourself. You feel like you are at the whim of a shaky brain that's going to fail you at some point. But when I met Chantelle and I met the other leaders, and they said, this is lived experience, this is normal. We are normal. We may be different from others, but this is also a different kind of normal. I think it empowered me. I learned that I could take control of myself, and I could also help other people to take control of themselves. I could advocate for people like me, for young children like me, who are always alone, who are scared. And so that's why I advocate from. I advocate from knowing that feeling of powerlessness, and knowing that when we stand up and speak about our experiences, even though they are painful, and even though that they make you feel shaky and out of breath, knowing that there's someone out there who's watching, and realizing that they're not alone. Just how I felt when I met Chantelle, and when I met the other young leaders, and when I learned about lived experience. I think that can change the world for them. It can make them hold on to hope. And I guess that's what we're working for. That's what motivates us as advocates. Thank you.
Yeah. Thank you so much, Grace, and for just mentioning how you sort of standing in the power of your experiences to initiate change in your life and other young people's lives as well, children and young people. And I'm going to bring in the next question to you again, Grace. Considering that you are what is termed a lived experience advocate, right? And you currently have access to powerful spaces, powerful decision making spaces, policy making spaces. For example, you are now a youth leader for the Lancet Commission, right? And you're also serving in the board on the strategic advisory board of the Wellcome Trust, right? I just want to find out a little bit more, or can you please share with us a little bit more about your experience in these spaces? Do you think that your voice is as impactful? Do you think that it's actually listened to and the action you propose is initiated?
Thank you. That's a good question. And I honestly have been thinking about this a lot in the past few days. I'm going to take a pause here to ask, can you hear me?
Yes, I can hear you.
Okay, great. Yes, so I'd say that I'm privileged more than other young people at this point because I do have access to these spaces. And some of the big I think have been that with other young leaders, we are starting to be heard. We are starting to be listened to. People have started using the term lived experience more often because this is something that young people have been pushing. They've been pushing for these in spaces that have, so basically what I can say is that we're standing on the backs of young people that have been pushing for lived experience to be more mainstream, beginning in the early 2000s. And so I have to recognize that. I have to recognize that there's so many people, mental health advocates, who push for this at a time when, we're still seen as demon-faced mad people. And they worked hard and they fought and they fought for this space. So I'm very privileged to be in a space like that. And I think that more than ever, people are starting to listen. However, one of the biggest challenges we've had is that the people who are listening are the people who wanted to listen in the first place. So like Wellcome Trust, they already had their agenda to listen to young people, right? They already planned for young people to be a part of their board, for young people to dictate how their programs are. Maybe this is due to the work of people before us, but they put us on because they have people that have been thinking like this. But it's still a bit hard for us to penetrate spaces as young people that are necessary, like decision-making places, like policy-making spaces, because they're still very resistant to hearing our message. They're still very narrative to change for many reasons. And that's the challenge. That's one of the challenges. The second challenge is when they say that they want a lived experience advisor or they want a lived experience person as part of their work, they always select one person, right? Or they always select just one area of lived experience, or just one. They never diversity of lived experience. They never think that there's another thing about my employers or people who I've worked with, but the people who I've spoken to in these conferences that we used to go to before COVID, we still see short-sightedness and tokenism as advocates. And I think we've now, introduced lived experience, and now I think the time has come for us to because what's the use of having a lived experience advocate if they're just going to be, like maybe white only, or, just one person representing the majority, or, we need to get rid of tokenism. And so I'd say my experience has been 50-50. It's very interesting to be a part of this, and I'm very privileged, but also we still have a long way to go. Thank you.
Yeah. Thank you so much, Grace. And you're actually right. It's a privilege to be in these spaces because it's there's so many barriers to actually accessing them. And you're talking about homogenizing of experiences. They're taking Lorato, and I'll be the only person who's being selected to represent young people in all the spaces, but I don't carry so it sort of defeats the purpose, you know. And earlier, Wenzile, you talked about how being a lived experience advocate sort of taught you that the knowledge that you bring in is important. You don't necessarily need a PhD in this area. The knowledge that you bring or that you've gained from your life experiences sort of qualifies you to be in this space. How have your experience been? I'm just extending the same question I just asked Grace. How have your experience been in these spaces? Do you think you're being listened to? Is there impact?
Thank you, Lorato. Thank you, Grace, for being so open about your story. And there's so much power in your story. I still see that even though we're on safe platforms like this, I didn't speak about my lived experience. I almost spoke about it as an abstract because you still have that fear that you will be judged according to your lived experience, even if in the safest of spaces, which is something that immediately got me to go back to a grassroots level and see how we can advocate. By grassroots here, I'm talking about tertiary. How we can go back there and how we can infiltrate, persuade and change the landscape of how mental health looks on campuses. So some of the work we've been doing here in South Africa is creating precedents for universities to create mental health policies. In our data collection from all the universities within South Africa, we found 3 universities that had a mental health policy, and out of 3 universities, only 1 was implementing the policies as part in their modus operandi as an institution. So one of the things that I believe has been a hindrance to implementing policy in tertiary education is resources. We found that there is a lack of resources or access to the psychologist, the counselor. People are not stepping up as mental health champions because of the stigmas that that are talked about when it comes to mental health. So you'll find someone who has been receiving help and does have a lived experience, but doesn't have the confidence and the voice to say that my lived experience is an empowering tool for someone else to drive change in their own lives. They see it as a thing that I need to deal with this behind shadows, behind closed doors, after the sun has set. And it became very increasingly important for us to prescribe when universities are drafting their own policies to consider stigma, destigmatization. So not only access of mental health facilities, but to almost recondition how people perceive mental health on campus, because a large population of students are facing mental health challenges, but they're not aware that they're facing mental health challenges because they see mental health as a one-dimensional thing. So depression, anxiety, there isn't that huge scope of different disorders and different disabilities. And on this side, on my side as an advocate, I don't blame them. For instance, the other day I was reading a document about the universal health coverage, and in it, when they were speaking about non-communicable diseases, they mentioned heart disorders, high blood pressure, low blood pressure, etc., and then mental health. And I was like, how? But where are the listings of mental illnesses? Or the non-communicable diseases, mental illness. So if people are being exposed to that kind of language and sneak it underneath the rug behavior, it is very difficult for them to step up, even as student leaders within the universities, to come up and say that, okay, we want to run programs where we champion mental health. We partner with universal campaigns like Speak Your Mind. You know, we make mental health not sexy. I don't want to use that word, but we make it as it is. Mental illness is if you have a mental illness, you don't have to now use the word mental well-being for the purposes of stigma. No, you destigmatize in your policies. You look at the linguistics that you're using and be very intentional about it. Be very intentional about the wording you're using whilst creating access. So it's been a huge thing on this side to create access, more access, because I was a person that was denied access for a large part of my lived experience because my disorder wasn't classified under prescribed minimum benefits. And I fought with the medical aides and said that what constitutes this as not to be a prescribed minimum benefit? Because if you look at basic healthcare, if I don't have this, I'm affected. Or if someone else doesn't have access to this kind of medication or treatment, you are potentially creating health hazards and illnesses that may cause fatalities in their lives. So it was a long journey, and eventually I was given prescribed minimum benefits for my disorder. But I probably am one in a million South Africans who have prescribed minimum benefit for my own lived experience and the disorder that I was prescribed with. So yeah, I think a lot of it is destigmatization and creating access and responsibility. Yeah, access in corporate social responsibilities as well. In corporate,
Yeah, thank you so much, Wenzile, for sharing that, and also the important work that you're doing with the universities and the mental health policies. When you were talking about implementing the policies, it reminded me of, there was a conversation around sexual harassment policies in universities as well, and how many universities have not implemented those, and there's an aspect of mental health in there that is lacking. And you talked quite briefly about some of the barriers. You talked about stigma surrounding mental health issues. And I think 2 months ago, there was a hashtag on Twitter when people saying, if our parents went to therapy with us, what would happen? And the responses you could see, I don't know if you saw that one. The responses they were sad and hilarious at the same time, but they were bringing to the fore the amount of stigma surrounding mental health challenges. And I'm going to bring it back to you again. I know you touched on it in part, but I want you to go a step deeper and just let's talk about some of the strategies that you think should be employed in overcoming some of these barriers regarding mental health advocacy.
I think debunking myths is one of the hugest aspects. Another lived experience that I have in my family is that I have an aunt who's now passed away, and her child was born with autism. And up until the day she died, her family held her responsible for the behavior and the state of this child because they were convinced that she dropped the kid. She dropped the child. And that is the reason why he's autistic. That is the way he's unable to communicate in a certain way. That's the reason why everything that he was experiencing was because of the drop. And it divided a whole entire family because they wouldn't take into account what Western medicine is saying around certain things, because there's also that thing that you bringing in Western culture and Western prescriptions of what something is. And where does that leave space for cultural knowledge? And I think the two have never fused, Western knowledge and cultural knowledge when it comes to mental health. So it creates a complete split, and it creates myths around albinism, Down syndrome, bulimia, depression, anxiety, all of that. I think a lot of work that has to be done is debunking the myths around mental illnesses, and I think holistic approaches. So instead of us always focusing on how we can treat it with one thing, your mental illness, look at holistic approaches to treating the illness, and trying to find different and dynamic, creative ways to be able to bring mental illness to the forefront in mainstream. Grace talked about bringing mental illness into mainstream. I think that is of utmost importance, because if it's in mainstream, then we get the impact, then we get the conversations, then we get the big guys coming in, then we get the funding, we get the money. But right now, if you look at the indicators under sustainable goal number 3, and where they said they'd like for mental health to be versus where it is now, the indicators show that it's going to dismally fail. The plan that World Health Organization has and the United Nations, currently there is very little progress. It indicates that the conversations aren't being pushed hard enough. They're not being put into the mainstream. So I think putting it first on the agenda, the way that women in the first, second, third wave, fourth wave, fifth wave, all the ways pushed for it to be in every single conversation. It is not a, oh, by the way. You speak about finance, you speak about mental health, you speak about farming, you speak about mental health, you speak about mining, you speak about mental health, speak about teaching, mental health, parenting, mental health, working in the entertainment industry, mental health. So mental health is an integral part of everything that we do. Thus, it cannot be considered as an, oh, by the way, topic anymore. It goes hand in hand with every other kind of program that is being pushed. So I think, like Grace did say, we need to fight for it increasingly to become part of the mainstream, but also being aware of what are the words we are using when we're pushing it into mainstream agendas. What are the linguistics around it? Because certain words and linguistics can create stigma. And stigma then breeds unfair discrimination. Yes, I hope I answered your question a little bit more.
Yeah, you definitely did. I mean, you touched on funding opportunities, because I mean, currently in the world, less than 2% of the global median for the health budget is allocated to mental health. Yet, as you're saying, mental health is an integral part of our lives. We cannot talk anything else and not also touch on the mental health aspect. I mean, just as the physical being is important, the mental or the psychological being is also important. You know, you cannot divorce the two from each other. So thank you so much, Wenzile, for sharing that. And time runs so fast when you're having fun. There's only 15 minutes left. And I'm going to take it to you, Grace. Grace, are you there?
Yes. Hi.
Aha, great. So we're going to try and balance. We have about 10 minutes left, so we're going to have to rush through the remaining questions. And Grace, I just wanted to ask you, looking at the next decade, right, here in the continent, what are some of the opportunities that we see in terms of mental health advocacy?
That's a good question. My overall dream for mental health is three-pronged, right? I hope that people with lived experience have more agency in my lifetime to determine what happens to them. And I don't care what they say. I hope that we are in charge of what happens to us. That means policy making, that means medication, that means, you know, life in general. I'm ready for us to take charge. I'm ready for us to have a voice. I'm ready for us to be mainstream. Sorry, Wenzile, I'm saying that again. Secondly, I hope that we can decolonize global mental health so that it reflects the perspective on ground. You know, I know that we've started with, you know, the friendship bench in Zimbabwe, where they use, you know, people, upstanding members of the community who old ladies who sit down and speak to young people. And that's how we used to be. That's African culture. That's using culture to change, right? To make change. That moves the perspective from old. African tradition is outdated and maybe bad, to we must use our culture if we need to see change in Africa. And I'm ready for that to become mainstream. I know that in Rwanda, we use community health workers to go and visit mental health patients in different villages, and it has proved life-changing, because I love telling this story. There's a village that I went to where former people with lived experience decided to become community health workers themselves, and now they're the ones doing the outreach. They're the ones going out into the villages to find the other people who have been alienated and shackled and all of those things, and now they're the ones making change. And that's what I wish for Africa. And thirdly, I hope that we start doing research led and done by local researchers, PI'd by local researchers, published to a local audience, so that we can put science in our hands, that we can provide evidence to our claims, and we can take charge of our own future. And that's also under decolonizing. So yeah, let's decolonize mental health, guys.
Yes, absolutely agree and love that, Grace, absolutely. So Wenzile, looking at the next 10 years, what are some of the major opportunities, major trends that we can leverage on in the mental health advocacy space?
Thank you, Lorato, and thank you, Grace, again for your insights. So I'm very excited for the future of mental health. In the late hours of the night, I am also a digital inclusion activist. So for me, the fourth industrial revolution brings many opportunities. There are issues that the fourth industrial revolution will bring about, such as isolation, increasing depression, anxiety due to social media, etc., etc. But I'm also very excited. Last year I was a candidate sent for One Young World in London, and one of the speakers there spoke around using games like Pokemon Go. There was a time that there's this game that came out, Pokemon Go, where you look for things and it's fictional characters, but allowing you to walk in real spaces. It was a trend for quite a while, but he was using examples such as that about how we can integrate mental health with technology. So in that instance, you are forced to leave your house. You are forced to leave isolation because there might be a point 5 kilometers down the road. You might have to talk to someone else, someone who's from a different culture, a different religion, a different race, because you're trying to win a game. So there are these things that you have to do, but that completely take you out of your comfort zone. So it's an amazing way to use fun and technology to come up with sustainable solutions for mental health. I also look at AI, artificial intelligence, and augmented reality as means to champion the fight for mental health to be in the mainstream. So for instance, with AI, with robotics and androids and humanoids being created, create companionship, program them, use the data that you get around mental health and program them to react to that, so that you can even have a space where technology allows you to predict when someone is in a danger zone of suicide due to the data that the program may have or the robot may have and how they react to that. So I think augmented reality is also something that's incredible, where a reality is put in front of you, but you're not there. So you can climb a mountain, you can ride a bicycle. In that same sense, you can have your therapist there, but almost in lifetime, where it doesn't feel that they're far or I'm zooming or it's a virtual. It's creating a reality that's obviously augmented in order to meet the needs of whatever the purpose of that augmentation is. So I think there's a huge space to get creative as mental health advocates around augmented reality and AI and gaming, and just to use that as a way as well to go with the time so that we don't fall behind, because we're already behind on the agenda. So now we're going to play catch up. No, we just need to dive right in there, see what technology there is, see what kind of programs there are, and influence with gamers, influence with programmers, machine learning. I think it's an excellent thing. We have those Fitbit watches. Well, I don't have a Fitbit, but there's those Fitbit watches, those smart watches that can take your heartbeat and your heart rate and your stress levels. What else can it do? If programmed in a way that we have influence and we have a say amongst the makers of these products, how far can we push the technology in order to include the mental health agenda?
Absolutely, Wenzile, absolutely. And when you're talking innovation, fourth industrial revolution, digital spaces, I'm also here thinking about accessibility as well. Not just access to internet, but quality internet where things are not freezing because and then somebody in the village does not get to access these wonderful programs that we're talking about. Like I said, time has just done a number on us. So I'm going to give the both of you 1 minute each, 1 minute on the dot, to just give us your final thoughts, your last closing word, so that we take it back to Chantelle. Wenzile, you may go ahead.
Thank you, Lorato. So for me, I'd just like to say to everyone, whatever your part is, whatever you believe it is, play it well. Be authentic to your own journey, whatever your journey comes with. It's not baggage, it's a lived experience, it's a human experience, it's a journey. So in that, hold yourself in high regard and know that you have power. Your story has power, your presence has power, your past has power. Every single part about you has power. You are God's gift to humanity, and the world wouldn't be as it is without you in it. And I just, love yourself, love the world you live in, make changes where you can. If you can't, don't blame yourself, you can't change the world, but love each other, have empathy, just be good to yourself and do good to others as well in whatever spaces you are in.
Thank you, Wenzile. Grace, are you there? Grace? I think we might have lost Grace there. Grace?
Yes, can you hear me?
Aha, yes, I can hear you.
Awesome. Okay, cool. Sorry. One, make accessible internet for everyone. Sorry.
Yes.
But
yes.
so one, my message to policymakers is that we are here and there's nothing to lose with engaging us as lived experience advocates. And so do that. Reach out to, there's people with lived experience everywhere. So reach out to them, have them give you wisdom, because we have a lot of it from our experiences. My message to other advocates is that your story is valid regardless. Don't ever listen to when people say that your story is too little, too much, or you didn't go through as much oppression as the other. Whatever you went through is valid. You do not need to compare yourself to anyone, and your work is valid, and we are seeing it, and we are holding you, and we are a sisterhood, or a fraternity. I don't know what the word is, but it's like a sisterhood, a fraternity. We see you, we're here, and we're reaching out. I mean, my message to people living with mental health challenges is that I love you and hold on. Things are changing. We are trying to change them. There are people everywhere trying to change them. So just hold on. Have that hope that it's going to be okay. That's it. Thank you.
Yeah. Sure.
Thank you so much, Grace. Thank you so much, Grace and Wenzile, for just taking out your time and having this conversation and just co-creating knowledge and sharing some of your perspectives, and also just sharing some of your intimate experiences around mental health. And what I got from the conversation here is that there's need for funding and prioritizing mental health. There's need for debunking some of the myths surrounding mental health issues, and also decoloniality, as Grace, you talked about decoloniality and research and knowledge creation around mental health in Africa, particularly by our researchers here, contextualizing the research so that we can use it for evidence-based approaches. And also with, as you said, the utilization of innovative digital spaces to create programs that can be accessed by all as we move into the next decade regarding mental health. So I'm very grateful to have been in conversation with the both of you. So Chantelle.
Hi.
Hi. Thank you so much for having us.
Absolutely. Gosh, guys, thank you for being part of this. It is just incredible to listen to you in the background. And I'm so happy that you were all three able to meet each other, because I think the three of you are quite a force to deal with. So I'm really happy that you had this conversation. It was so inspiring. And as a mental health advocate myself, I understand the vulnerability that you go through in sharing any of your experiences, and also the impact it has and the possible exhaustion it has in being an advocate and continuously speaking about things that are quite personal and that are impacting other people. So I would like to say thank you for giving energy and time to this today. And yes, we will be hosting we are hosting this on the 10th of October, which is in commemoration of World Mental Health Day. So it certainly is the right time. And I think there are a lot of young people and a lot of people who can find a lot of inspiration by what you have said today. And yes, we are certainly willing to engage further. And you are also able to connect with them over different social media platforms. I know that Grace and Wenzile are quite active on socials. I'm not sure about Lorato. I don't follow you, but I'm sure there might be some connection there too, but we'll post that on the links too. So thank you again to everyone. I think what I wanted to do before we go, if we can have one quick selfie and give us a good smile, because a smile's also good for your mental health. So if you can give us your best ones, I'm going to have a quick selfie. And yes, let's do it. I'll count us down. 3, 2, 1. Brilliant. Thank you, lovely ladies. We'll be in touch soon, and take it easy. Take care of yourselves.
Hello, everyone, and welcome to our 6th annual Durban Mental Health Symposium, which, due to the COVID-19 pandemic, is being hosted online this year. Even though we are not getting to meet in person as usual, we've still managed to secure a stellar lineup of speakers and mental health activists who are here to inform us and enlighten us about how we can think, write, and practice differently in the space of mental health. As always, the symposium is hosted by the KZN Mental Health Advocacy Group and co-hosted by the South African Depression and Anxiety Group KZN office. And this year, one of our co-sponsors is also SAISA, which is the Psychological Society of South Africa. In this segment, I am honored to interview Dr. Rochelle Burgess, who is a psychologist based in the UK, but who has spent a considerable amount of time in South Africa and is no stranger to KZN as well. Dr. Burgess is a leading figure in the area of global mental health and community mental health and has some very interesting thoughts and ideas about how we can make our research practices and even our own work more transformative in bringing about real change to society. So I hope you enjoy this interview. Thank you for tuning in. And without further ado, let me introduce Dr. Burgess a bit more extensively. Dr. Burgess is a leading community health psychologist who specializes in community-based approaches to health, and her work studies the social and psychological dynamics of community engagement using qualitative, participatory, and transformative methodologies. She is currently a lecturer in global health and a deputy director at the University College London Centre for Global Non-Communicable Diseases. She is the founder and the director of UCL's Global Network on Mental Health and Child Marriage, and she is a fellow of the Royal Society for Public Health, among other affiliations. She has a very extensive CV and has done a host of interesting work over the years. I highly recommend people Googling her and reading some of her very, very interesting papers. In 2020, with colleagues at York University, she launched a network on participatory approaches in global health, of which she is the co-director. Ultimately, her work is about the intersections of poverty, gender, systems of governance, and civil society, and looking at ways in which we can respond to the political economy of poor health. For the past decade, she has focused largely on mental well-being and the experience of common mental health disorders, and she's become a leading voice in the emerging field of social interventions in global mental health, of which she'll speak more about in this interview. She has led a range of projects, including in places like South Africa, Colombia, the UK, Zimbabwe, and Nigeria. KZN, like I said, is very much another home for her, as she lived and worked with HERD at the University of KwaZulu-Natal as a research intern early on in her career, and she then did her PhD fieldwork in KZN a few years later. She does say that she returns to KZN whenever she can, and I'm sure as soon as all our borders open, she will be back again. I hope that you enjoy this interview and that you learn much from it, as I hope to as well, as we get to engage with Dr. Rochelle Burgess. Rochelle, so the first question that I have in mind was just for you to tell us a little bit about the work that you do, and maybe just tell us what's inspired some of your current professional interests.
Okay. So a lot of the work I do is rooted in ideas of community engagement, and that the voices of the people that sort of systems are designed to help are included and taken up in the programs that we develop to help them. So I spend a lot of time thinking about the gaps between really nice policy on paper and the impacts of those ideas in people's everyday lives. I spend a lot of time thinking about how do I use my relative position in the world to give voice to people's voices who are often excluded or overlooked or muted by the different sort of processes and practices of academia. How do we think about the promotion of mental health? And I guess a lot of that comes from a few things. In one part, my training as a community health psychologist and a discipline that is very interested in social justice and social movements and to improve societies so that people can live well. It also comes from my position and background as a person who has been excluded in certain spaces, whether that be as a woman of color or as in the space of my life as a service user researcher. I have used mental health services for many years at many different times in my life, and often felt that disconnect between what I was saying and what I wanted to say and how I was heard and how systems heard me, and sort of friends and colleagues and people who have had similar experiences to that. And I guess the third thing, which, if I can remember what that third thing is, I guess I very much feel that research can be a space for bettering the world, if we use the right methods to do it. And so I've learned a lot actually from South African scholars in my ongoingly, but very much so in my developmental years, such as Inge Peterson and Kathy Campbell, and many others who sort of looked at psychology in a very different way to what I was originally taught in Canada when I studied in Canada, and sort of highlighted how it's a discipline that can be about more than the sum of its parts. So I guess that's sort of me in ensuring people have access to care, and that care is an appropriate reflection of what people say they need when they tell us what they need.
I mean, that's so fascinating. It sounds like the kind of general theme of inclusion is quite important to some of the work that you've been involved in, and kind of including people who've been historically excluded from different sorts of spaces around mental health. And would you kind of particular challenges around getting people included who've been historically excluded?
Well, I guess there's two things. So one of the things is that research itself is often conducted in spaces and languages that everyday people don't speak. And this is not just about sort of like English language, which is one part of that, but it's also sort of the languages of academia. So we talk about things like statistical significance and objectivity and knowledge paradigms and all of these sorts of things. And they have an important place in ensuring that what we do design is effective, but that is not without a cost. And I think for a long time, those costs have been underappreciated in terms of what voices are left out of discussions and debates on what are the solutions that need to happen. And I guess what has really struck me in sort of working in mental health spaces in the last few years is the way we think about community mental health and the different types of community that are excluded from that. So in a way, we're very good about thinking about service users, right? So we can think about a service user identity in a very good and clear way. But what often happens is the other dimensions of a service user's identity, to use sort of like social psychological and community psychology terms now, these ideas of personhood are not included. So the fact that you are a service user intersects and overlaps with the fact that you're in poverty, or that you were married before the age of 15 in a child or early marriage, or that you were a victim of sort of violence, whether that be state violence or violence of an types of intersections around a service user identity don't often get picked up in the same way. So we're really good at inclusion in one way, right? We're really good at saying, okay, service users must be in panels and service users must be involved in research, but it's very rarely on terms that are equal in power or that pay attention to the multiplicities of sort of exclusion and oppression that can happen in a service user's life. So I guess another big thing that I talk about a lot is these intersectionalities of a person and how any one person can actually reflect half a dozen different communities of interest. And sometimes those communities of interest are also points of exclusion. And so as we make spaces for service users, I think part of that is also making spaces for the totality of that experience, thinking about what are the stories and the realities that feed into the development of a mental health condition in any way, shape, or form, whatever pathway that happens to.
I suppose a part of foregrounding that intersectionality is also then highlighting these kind of power imbalances that you spoke about. And it in some ways maybe perhaps links to an article that you recently wrote in Nature about COVID-19 and mental health responses in relation to that and the kind of neglect of social realities. And I kind of found that kind of idea quite interesting because it seemed like you were, I think, quite directly and rightfully so critiquing the overly individualized nature of our mental health responses during COVID-19 in particular. Do you think that people are paying more attention to social realities in the ways in which you think are helpful and useful for service users, or do you think we still have quite a long way to go in that regard?
Oh, that's a good question. Sometimes I feel really hopeful. I mean, I think 10 years ago, that piece that I wrote in Nature would not have been in Nature. I had a piece published in Lancet Psychiatry actually sort of around this time last year that I wrote with Sumit Jain from University of Edinburgh and Inge Peterson from UKZN and Crickland from UCT about sort of social interventions in global mental health. And in that piece, we talk about moving beyond sort of the medical. And I didn't think that was a thing that I would ever see published in the Lancet Psychiatry. So I think that we are definitely living in times that are more open to these ideas in ways that we haven't seen before. But I think there is still further to go. And I sort of will have to use these opportunities to sort of leverage and develop new types of projects and new ways of thinking that focus a lot on transfer of power and ownership away from the traditional spaces that may have held them. I think that, we're sort of in a time where there's a good opportunity for that. And I've seen some really interesting work coming out recently on sort of looking at cash transfers, for example, and unconditional cash transfers and their impact on mental health in households, and sort of highlighting that actually they have a huge positive impact on mental health in households, which is now evidence to support what a lot of sort of ethnographic and life history work that I've done and many before me have done to say that poverty is bad for people's mental health. And so there's now a coming together of disciplines that used to sort of not really speak to each other, and that is something that's hugely positive. And so the trick will be to sort of think through what that looks like in service design. And so one of the things I'm really adamant about is if you work in a truly sort of participatory or co-production paradigm, then I always sort of say to my students that participation, when it's working, if it's working in a transformative way, should feel at least once like everything's going to fall apart. Because if you feel that way, then that means you're giving up power. and you are giving up control, and you are allowing somebody else to talk about and dictate what this should be. So when you feel that way, then there is a transfer of power happening. That's what that discomfort is. You know, power is never conceded without demand. Power is never given up without demand. So you should feel those tensions in the participatory, co-production, engagement type of work that is happening, because it means you are giving it to somebody else to make that decision. And I think it's on all of us in global mental health to start thinking about how do we work in different ways that do that in a real meaningful way. Because I think that's one of the most amazing things that I have found over the years, not just in South Africa, but other places. I've worked in Colombia, for example, in sort of around post-conflict mental health or reconstruction type of work, is that people survive things all the time. They are surviving every day by virtue of showing up to participate in a research project. They are surviving to highlight and support people's survival rather than automatically dismissing it or paying attention to other things. Can we do things like community-based research and participatory action research, where communities have the driving stick in sort of what an intervention might look like, and its development, and evaluate it and talk about things like scale up. So constantly rethinking what research is for and who research is for. And I suppose for me and many colleagues that I work with, research is a vessel or a pathway through which in their everyday lives, and treating it like that as much as possible. I don't know if I answered that question.
Yeah, absolutely.
Or if I just sort of meandered into a new question.
No, I mean, it's
yeah,
so fascinating. I think just listening to your thoughts on this, and I love the idea of everything feeling like it's falling apart, and that's when you know that you're really kind of handing over power. And I imagine this is difficult for kind of mainstream research that almost prides itself on pre-planning and having everything go in kind of predetermined route. Do you kind of have any advice who are kind of treading this quite carefully and for whom this might be quite new? How do you manage that uncertainty, which is probably something that doesn't come easy to people who want things to turn out in a way that they imagine it would eventually?
Yeah. Yeah. I mean, I think, look, it's still not even easy for me. When I have those moments, I still think, oh my God, what's happened? Is this all going to fall apart? So I think it's important to, I guess, normalize that. But one of the things that I have found is most important to that well, there's two things really. One is around communication, and sort of from as early as possible setting out, everybody can talk about what it is that their desire and hope is from the work. So what is it that what are people bringing to the table in terms of their hopes and dreams for this collaborative piece of research? And from very early on, trying to find the places where you overlap and what those similarities are, because those similarities are the things that get you through the difficult times that might come. Sort of reminding yourself and each other that you're all sort of moving in the same direction together. But you need to have had that opportunity to really talk about that and talk through that. And I suppose then one of the other big things that this requires is time. And of course, then this starts to intersect with the very real world limitations of funding windows from different funders, and how long your grant is, and how much time in the real world is actually available. But you need time for things to fall apart and then come back together again. So I think the way you get around that is being realistic right at the beginning as to what a project is able to achieve, and start to build work with your partners in a way that says, look, we might have this funding for a year or 2 years, but we are in this to work together for the next 10 years, you know? And so if that's the case, what are our short-term goals and what are our long-term goals, and what are we going to do now, and how are we going to work together to achieve it, and what are the things that we sort of keep on the back burner as we move on down the line, and how do we keep as much of everybody's vision or desire for what we'd like to achieve in each time as we go. So yeah, I think those are the biggest things for me. I had this real privilege of doing an evaluation of an organization that has been working on co-production for like a decade, possibly a little bit longer. And, you know, the fact that that is how they were able to achieve sort of change, that transferred power. A lot of things stopped and started, and it took a long time, but if they got there because they could do this over a period of a decade. And, you know, I think in a way, it also requires that we reevaluate our idea of wins, which is the hardest thing, I think, working not just in research, but also in a social justice framework where need is very pressing and we want to make things better now. And it sometimes can seem very large. Another thing that I have said to my students in the past is that if you work within a paradigm of small wins, and our small wins sort of over time accumulate and build towards big change, you know, it's very rare that somebody's able to snap their fingers and poverty is gone overnight. So if it was possible, it would have happened already, I would have imagined. And so how do we all work in parallel ways towards short-term, mid-term, and long-term goals? And sort of having those in mind helps with that disconnect and those feelings about falling apart. It sort of reminds us that this is a marathon rather than a sprint.
Yeah, I mean, I suppose in the kind of like publish or perish culture that most universities locate themselves, you know, it might be quite difficult to kind of convince people that these long-term collaborative partnerships that are a more kind of slow cooking approach to academia actually will yield greater fruit in the end. As compared to kind of like swooping in and just kind of evaluating something or doing a quick intervention, you know. And so, I mean, I imagine that this kind of thinking still remains marginal in the global north, and probably largely assuming because of the kind of domination of Western individualism, if I put it quite crudely. But I mean, I think you've given us some amazing ideas about how we can kind of think differently and out of the box and perhaps even kind of move past this. Do you think that the COVID-19 context has kind of created opportunities for this that perhaps would not have presented themselves had we not had this pandemic?
Yeah, I find that really interesting. I think my answer to that is sort of yes. It showed me ways in which that we had learned, but didn't realize we had learned. So, for example, if I think about where my career started in and around HIV and AIDS, and how many years it took for people to sort of acknowledge and name the fact that systemic inequalities were at the heart of why HIV was more prevalent in some places than others. Years, like a decade, maybe more, to sort of start to get those, like the language of syndemics and multi intersecting pandemics, and to get that language sort of picked up in policy and practice took a really long time. And with COVID, it happened relatively quickly. We talked about mental health, you know, in terms of talking about mental health and HIV, that took a really long time. It took a month to get that discussion happening around COVID. And then it took another couple weeks to get people to say, hang on, COVID doesn't happen in a vacuum. It's happening in a world that was already unequal, that inequality has bearing on people's well-being. It's not just about disorder, but sort of very normal for us to experience distress as a result of a pandemic that has an unequal distribution of impact across society. And so how do we think about mental health in those dynamics as well, so we don't over medicalize everything to the point that we're forgetting the social reality, but still create pathways and supports for real and meaningful mental health conditions when people do experience them. Those debates happened very quickly. It didn't take a long time for them to happen, which was a real sign of hope for me, that actually things have changed and things do change. And I think because we're already having those conversations about inequality, it makes conversations about power that much easier to have. And those are the types of conversations that need to be had in order to get towards that change that we're seeing. And I think that, just to touch on something else you said about the publish or perish mentality, I sort of feel that, at least in the global health space, that feels a little bit like it's changing. I think people don't necessarily want a publication just for a publication's sake. More and more, the ones that have the biggest impact are the ones that say something meaningful. And it takes time to figure out what the meaningful thing is to say. Now, of course, the time that takes differs by discipline. So it's a bit easier to perhaps do a statistical analysis versus doing a qualitative analysis of 100 interviews of women that have been taken over 3 years. So those timelines themselves are different, but I think the outputs are still both equally meaningful. And it just sort of makes me think a little bit about a comment that Richard Horton sort of published a few months back before COVID about sort of the hazards of just consistently doing sort of like systematic reviews, like the review pipeline, and sort of what are we reviewing for, like, and so I think people are asking the types of questions we need to ask to change that language around publish or perish, which then changes the way academics feel that they can engage in a space, because it is very much about these intersecting pressures. And so hopefully bit by bit, changes happen in different spaces that can leverage and contribute to change in new spaces. And I think we are starting to talk a lot more about academic culture. And as those conversations continue to happen and those things change, the rest of it also, it creates room for other things to change as well.
Thanks, Rochelle. I think I'm also kind of beginning to think about the kind of intersections between global mental health and community mental health, and what your kind of understanding is of where the synergies are and where the kind of differences lie. Because I suppose sometimes when we talk critically about both fields, it almost seems like we speak in the same language, but at other times it seems like we kind of like poles apart. So I'm quite curious to hear your take on the kind of intersection between these kind of two related but slightly different fields.
Yeah, so I guess in a way, in global mental health, there is an interest in communities. And so, and that sort of comes from sort of a legacy around deinstitutionalization and move towards community care that is very much a pillar of mental health practice globally, right? And so the language of community comes in that space, and it also occupies a similar language around the role of how you then successfully deliver care in the community. So then there is interest and engagement with community actors and members, and in order to make services more accessible. So very much these interests around community mental health fit with these desires to increase access to care, and also this sort of legacy of care in the community. I suppose where it starts to fall apart a little bit for me, and this might be from my training and knowledge of community mental health from a South African disciplinary backing, is that there is more interest in sort of ideas of justice and sort of like socio-political justice and how that relates to mental health in sort of a community mental health space then tends to be spoken about in a global mental health space. There's definitely an interest in justice and fairness and equality, particularly around sort of this idea of access and sort of reducing the levels of institutional care and reducing abuses that people experience in relation to having a mental health condition, and sort of practices that get a lot of discussion in that space around things like chaining and those types of practices. But as yet, sort of in those mainstream spaces, the movement to justice has been a bit slower in talking about justice around structural violence. Might be a nicer way to summarize that. Where I felt, at least, has always been the narrative in community mental health and community psychology, at least in South African disciplines and European disciplines. So yeah, but I think that gap is definitely starting to reduce. You know, when, yeah, it's definitely starting to reduce, that gap is starting to reduce. But when I started the work in global mental health, you know, I guess in 2010-ish, with my PhD, there was not that kind of discussion around structural violence and the relationship of structural violence to how the field was responding. So it's definitely happening now. So I think over time, that gap will continue to get smaller. And that's something to be hopeful and positive about, I think.
Thanks, Rochelle. You've mentioned your time in South Africa a few times, and I know that you were in KwaZulu-Natal specifically. And do you mind just telling us a little bit about some of the work that you did while you were here and how that specifically has kind of impacted on your thinking and on your professional development?
Oh gosh, yeah. So my first piece of research and work that I did in South Africa was actually with the South African Depression and Anxiety Group. And I did an evaluation of the speaking books intervention as part of my master's research. I think it was in 2007 or something. And I got to spend time with different communities who had been using the intervention and doing that kind of work, and also with another program, Similando, I believe it was called. If forgive me, it's a long time ago now. But that intervention, they did something sort of, it was sort of like an oral history type of program, and they did work around memory boxes, and it was around promoting young people's well-being using that intervention. And in those evaluations, when I spoke to facilitators, and we talked a lot about what works, because I'm always about thinking about success first. And then the sort of wrapping up question is, what would be the thing that you would change if you could change anything? And even though both groups didn't really know each other and they were working in different parts of the country, I was doing work with SADAG in Joburg, and Similando was in KZN. They both said the same thing. They both said, well, you know, people talk about poverty and how poverty relates to everything they're feeling, and we don't have anything for that. We don't have anything to support or promote or direct that. And so really this piece around inequalities of an economic or social nature, sort of things around gender also came up then, and what was being missed from facilitators, that has always stuck with me. And then when I did my PhD, it was when I was based at UKZN at Hurd for a while, and then did a PhD in Durban after that placement. And in my PhD, I did some life history work with women who lived in northern KZN by the Mozambique border. And they had participated in a sort of a large epidemiological study that was looking at understanding prevalence of mental health disorders in communities. It's run by Lucy Kluver at Oxford, and she very kindly allowed me to do some qualitative work linked to that study. And we did these life history evaluations with women, and I learned some Zulu, and I was very bad at it, but they were very kind to me. And we talked about their life, and we talked about the survey and their symptoms in the context of their life. So now somebody might call that a cognitive interview, where you start to look at the questions and, you know, whether and how people thought about the questions when they were answering them. And one of the things that came up in that interview again was structural violence and poverty and inequality, and these inequalities and how they very much shaped their symptoms of depression and anxiety or PTSD or any sort of symptomology. They rooted it in their stories of struggle. But they also had amazing ways that they were coping and surviving every day, which sort of led to sort of a couple of my papers that you may be familiar with, and sort of fed into a special issue in transcultural psychiatry, looking at the role of communities in the space of global mental health. In 2012, that came out. And then I guess one of the other big things that's always stuck with me was the piece with, sorry, there's an ambulance going by, was the piece with health systems in that PhD work. And I spent a lot of time with people who sort of made the mental health infrastructure and sort of the primary healthcare model in Kwanagazi, and how they all knew, everybody knew that they were only offering a partial response, that they were doing the best they could in the context of what they had. And the thing they wanted to change all the time was that they didn't have anything to speak to the complex realities of people's lives. If a woman came to them and said, I'm depressed because my children are starving, they didn't really have things to give them. They had to work within sort of the wider structure, and then there were barriers to that. And so that has really propelled sort of the rest of my career in trying to sort of solve that conundrum of how do we fix what we have on offer so it matches what people are asking for. And the ways in which and the solutions that I come to often come back down to how do we engage with and involve communities in the design of what's on offer, and bringing that design and development and evaluation closer and closer into communities themselves, which are as complex as they are in real life, and moving on from there towards action. So everything I do is because of my time in South Africa. I'm still there doing stuff. I've just added other countries. I've never taken away South Africa. It's very much my, I suppose, third home now, because I'm originally Canadian and then I now live in the UK. But South Africa and Durban especially is very much home for me. And I will be back as soon as the borders are open to us to do some more work. So yeah.
Has your isiZulu improved yet, Rochelle?
No, it got worse. It only got worse because I stopped being embedded in where I could hear it. But I still know how to say hello to aunties. So I suppose that's enough.
Yeah, I think sometimes just saying hello is enough to just inspire that first connection, eh?
Yes, yeah. They were always shocked, right? And I was in a community where there had been lots of research done. And for me to come in and say, Sabona ma, and they'd be like, what? And then they'd laugh at me and I'd say another sentence, and my few sentences were very much, I'm very bad at Zulu. I'm very sorry, ma. My researcher will do most of the talking and she and I will all talk together, but I'm not very good. So, and that sort of engagement, I mean, it was much appreciated. But maybe one day my Zulu will get better.
Rochelle, I think a lot of what you're speaking about also links to stuff you've written recently about the kind of political economy of mental health and how it matters and has always mattered. But I think political economy often doesn't enter conversations about mental health. And I think you kind of highlight, I think, almost the tensions, but in some way, the creative tensions and the kind of possibilities that might be able to arise if we use kind of political economic thinking a bit more in terms of how we think about mental health. Do you want to say a little bit more about this?
Yeah, sure. So I guess I sort of came to the sort of a political economy lens in a space where I was not thinking about mental health originally. I was thinking about violence against women. And Jackie True has written an amazing book about the political economy of violence against women. And the way in which that lens allowed her to really appreciate not just the sort of like the manifestations of sort of structural violence in people's everyday lives, but the fact that this is embedded within sort of big systemic political structures and environments, just sort of like opened a key in my brain that really, got to the heart of this poverty problem, because poverty in the lives of the women that I have worked with over the years in South Africa, and in the communities I've started working with in Colombia recently, and the new work that I'm starting to do around mental health and child marriage. Poverty is a big feature there, but poverty is connected to all these different things. It's connected to gender inequality. It's connected to migration patterns. It's connected to sort of geopolitical relationships between countries that mean that some countries are more likely to always be poor and some countries are always more likely to be rich. And I think in a way that becomes really important for allowing us to see the many different levels that work needs to be done at, right? Because if we focus very narrowly, too close to home, just on an individual, just on a patient, or just on their community, or just on their family, we fail to realize what's creating these pressures and maintaining these pressures in the first place. Because, you want to say things like, well, things will be fixed if we just get people access to cash transfers. Well, cash transfer programs are brilliant, but they need to be paid for. And so if we're going to set up a new infrastructure, we have to be thinking in a way that reminds us that there's also pressures on a cash transfer program and where those fundings will come from. So it cannot be and is unable to be the primary solution forever. It is something that we can have in an interim while other work is done in other spaces and to do other kinds of leverage, right? So for me, a political economy lens reminds us that bodies and minds and our mental well-being is always enmeshed in these big, broader structural relationships, so that we don't, I suppose, in essence, burn out as we try to find solutions to very big problems, but our solutions are very small. So it's thinking about, it opens up an opportunity to think about where different levers need to be and who different audiences are that we need to speak to when we do different types of policy engagement and make recommendations around different types of action. So yeah, watch this space for a paper in development with some colleagues around, how important this is and why this is important. Because it's something that we haven't thought about a lot or enough, but touch on in a lot of different ways, but not in an interconnected way. So, yeah.
Rochelle, some of your work and some of what you're even saying right now about political economy, it seems to intersect with what might be termed the decolonial turn in psychology. Related conversations about how to decolonize psychological interventions. And it also links to some of the stuff that I've been thinking about and also writing recently around decoloniality and psychology, which has also taken hold quite strongly in South Africa, with some strong influence by Latin American scholars as well. I mean, what are some of your thoughts on the kind of decolonial turn in psychology?
I suppose in psychology, it's long overdue. Long overdue. But yeah, it's long overdue. I'm just really happy that it's happening. And maybe it's sort of existed in different ways, under slightly different headings. But I think there is a value to naming it as decoloniality and under a decolonization heading, because in a lot of ways, how we understand the mind is very much through a Western lens, and how we promote solutions to challenges of emotional well-being and psychological well-being doesn't give as much space as it should to those alternate realities. And I think perhaps a lot of sort of critical and transcultural psychiatry and psychology has been pointing in that direction for a long time. But what decoloniality allows us to do is embed that into a structure of colonialism and racism, and these are really big challenges that, you know, thinking about racism in particular is not really given space in psychology, even though it's not a very good history. So, and other sort of points of exclusion around race or ethnic difference, xenophobia, and for example, would be another one. But yeah, I think the time, I'm glad that it's happening. I mean, it feels like there's a lot happening, right? Sort of like the decolonial turn, and sort of like more and more in discussions about power, and but I think only good things will come of it. But there is that definite discomfort, and you feel that discomfort in some spaces and with some people about what this actually would mean in practice as we start to change things and change the world and redistribute power. So, yeah.
Thanks, Rochelle. I mean, we're going to wrap up the conversation because we've just got a few minutes left. And
Yeah.
our theme of the symposium this year is actually looking ahead into the next decade. And what we've asked all our speakers is to imagine that they're in 2030. And if you had to look back on this decade that we're entering, what are some of the kind of hopes and wishes and dreams that you might even have for where, in your case, community mental health might be moving, but perhaps also even global mental health more broadly? And what are some of the more radical changes that you would hope to be actualized in the next 10 years?
Well, I suppose in the next 10 years, I would love to see strands of funding and research that are focused specifically on scaling up and supporting Indigenous responses to care and treatment, not to change them or build them into hybrid methods, but just to understand why they work and highlight why they work and fund them so they can become more permanent infrastructures around the world. I think communities have solutions already, and we spend a lot of time trying to change those solutions into a different language. And so I would like in 10 years' time for that not to be the case. I guess I would also like to see I'd like to see global mental health thinking about a few different things, actually. So another strand in my work that often doesn't get spoken about as much is this thing about racism and mental health. And I do that work, and the reason that doesn't get spoken about is because I do it in the UK. And so for some reason, the work I do in the UK does not count as global mental health. Why is that? Well, that is because global mental health is very much like global health, a discipline that actually is about those very old colonial relationships about sort of rich countries versus over poor countries, or working with poor countries. Sorry, not over, but in collaboration with. And you know, there's a recent paper that came out in BMJ looking at where global health master's programs are in the world, how much they cost, sort of these huge systems sort of built up and around that kind of disparity. And so I guess in 10 years' time, I'd like to see work that is done around these shared challenges of inequalities and oppression and access in high-income countries to count as global mental health. You know, what do we mean by the globe? That should be problematized more. And also for as a similar way of sort of recognizing expertise in countries where the challenges are, more and more programs that are in those countries, right? So masters in global mental health in South Africa. Well, there's the public health one at UCT, but you know, MSc programs in countries what the world, that the discipline is about, that the program is about. And I guess the third thing I'd like to see 10 years from now is the normalization and the embedding of transformative research approaches into everyday practice. And sort of what I mean by transformative research approaches is that research is designed for the purpose of changing something, and that there's always a tangible changed outcome that happens through the conducting of that research. So what is it that people leave behind? There's something that is left behind that is positive out of the research, not just the research project itself. And for that to be the norm rather than the exception.
I mean, that sounds fascinating, and I'm crossing my fingers, hoping that these are actually the things that happen in 2030.
Yeah, it could happen. It's totally possible.
Rochelle, thank you so much for a fascinating conversation. I wish I had a whole nother hour with you because I have so many more questions to pick your brain on. But one of the things I'd like to ask you, and this is maybe a little bit more personal, which is what do you do for your own mental health? Because, you know, those of us who are in the mental health space are at risk of burning out ourselves. And so kind of what's on your list of things that keep you fresh, keep you alert, and keep you okay?
Yeah. Well, I suppose there's three things. One is therapy. So I make time for therapy in my life. And it is sometimes less frequent than others, but sort of what that does for me is creates a space to talk through some of the things that are quite big and heavy and we can't sort of get through on our own. And I find that to be a necessity for me. And I talk about it a lot to try and normalize it, but you know, I think it's really important. Other than that, I think I have this practice that I sort of do with my partner and my family, my wider families. When things are difficult, I sort of try to get into a practice of asking people what are the sort of asking ourselves what are the top threes for the day, or the top one for the day. So what is the one thing today that brought you joy, or what are the three things that you enjoyed today? And at the very least, people can find one. Sometimes you can't find three, but you can always sometimes find one. And trying to create a space to think about things that have gone well or made you happy, because it's very easy to just remember the things that haven't gone well and have been really tough. And it just sort of is a way that also reminds us of our own survival and reminds us of the fact that we are surviving and thriving, hopefully. And then the third thing is, it's a bit personal, but I don't mind saying it. And I've just sort of remembered that like dancing makes me really happy. So it's just sort of this idea around sort of like the physicality and physical health and how important it is to you. But for me, you know, I guess since becoming a mom and moving out of the city, one of the things that fell away was dancing. So, you know, unless you're going to someone's wedding, like, you know, I'm not dancing anymore. And I've tried to actually just put it back in, just sort of like dance around in my living room. Which I started doing again when Beyonce's new album came out. And I was like, oh, wow, that feels really good. So now I just dance a lot more, just by myself. And it's fun. Well, sometimes my husband dances with me, but he doesn't have to. Still happens. yeah, those three are really helpful.
Thanks, Rochelle. I think that's a fantastic list. And I think there's a whole nother conversation there about kind of centering the body more in mental health.
Yeah.
Yeah. And how
yeah.
kind of there is that disembodiment sometimes in the kind of work that we do and in the way in which we think about mental health. Rochelle, thank you once again for taking time out of your day and for participating in this amazing conversation. There's so many gems that I'd like to kind of pick on, but I think I'll leave it to our viewers and our listeners to take what they want from this conversation. And I think your kind of hopes and dreams for the future also, I think leave us with the promise that global mental health and community mental health actually have a huge role to play in kind of improving the societies in which we live, in attending to the issues of structural violence that you spoke about. And I think just paying more attention to the kind of power imbalances and how we can kind of disrupt that in the ways in which we think about mental health, in the ways in which we do mental health, and the ways in which we write about mental health. So, keep doing the amazing, awesome work that you're doing, inspiring many of us from afar. And I hope that our paths get to cross in person when you're back in South Africa, specifically when you're back in Durban.
I definitely will let you know. Don't worry.
Great.
Thank you so much for asking me. It was a pleasure.